All right, listener, get ready, because today we're tackling your notes on assessing respiratory distress.
Yeah, it can be a lot. So think of this as your fast track to really mastering those essential techniques.
Perfect.
We'll extract the most memorable parts and give you that solid foundation and maybe even some aha moments along the way.
Love it.
We're going to go on a deep dive.
A deep dive into respiratory assessment.
That's right.
Okay, so your notes start with the 4 steps of assessment: inspection, palpation, percussion, and auscultation.
It's kind of like building a house. Each step is laying the foundation for the next.
Makes sense.
But let's break down why each of these steps is so important.
Yeah, please.
So inspection, that's where we're just looking at the patient. We're gathering those first clues about their respiratory status.
Right.
Think Sherlock Holmes just scanning the scene for subtle hints.
I love it.
Palpation, that's using our hands to feel for any abnormalities.
Okay.
Is the chest expanding symmetrically? Are there any unusual masses?
Gotcha.
Percussion that's tapping on the chest helps us assess what lies beneath. Are the lungs filled with air fluid or something else?
Okay.
And then finally, auscultation.
Okay.
We're listening with our trusty stethoscope.
Yes.
And that allows us to hear the breath sounds and identify any irregularities.
So it sounds like we're like a detective, gathering evidence piece by piece to kind of solve the mystery of what's causing the patient's respiratory distress.
Exactly.
I like that analogy a lot.
Now, your notes really emphasize the power of visual inspection.
So you're telling me just by looking at a patient, I can glean all this crucial information.
You'd be surprised how much you can learn from observation alone.
Really?
For instance, seeing a newborn with flared nostrils.
Oh, yeah.
That tells us they're working hard to breathe. They're trying to pull in every bit of air they can.
Yeah, that makes sense.
Now think about cyanosis.
Cyanosis, so that bluish tint
Around the lips?
around the lips.
Yeah, that's a pretty clear sign something is wrong.
Right.
There's a red flag for hypoxemia, meaning that the blood isn't carrying enough oxygen.
Okay, and speaking of red flags, my notes mentioned pursed lip breathing.
Yeah, it's almost like patients are instinctively doing it.
It's like they know.
But what's the physiological purpose behind that?
Why are they doing that?
It's actually pretty ingenious.
Like,
By creating that resistance during exhalation, they're essentially creating their own PEB vice positive expiratory pressure.
oh, wow.
And this simple technique can dramatically reduce air trapping in the lungs, especially in COPD patients.
Interesting.
And it can even increase their exercise capacity.
Okay, so pursed lip breathing is actually a good thing in that situation.
In that situation, it can be very helpful.
Okay, good to know.
Now, another interesting thing to look at is the neck.
The neck.
Yeah.
I wouldn't think the neck would tell us about breathing issues.
Well, have you ever heard of JVP?
JVP.
Jugular venous pressure?
Okay, so tell me more about that.
It reflects the pressure in the right side of the heart,
Okay.
which is directly linked to the lungs. So if the JVP is too high, it could suggest issues like heart failure or even a buildup of fluid in the lungs.
So measuring JVP is like getting a sneak peek into what's happening deeper inside.
That's a good way to put it.
So in my notes, it says to position the patient at a 45-degree angle. Why is that so important?
Well, think of it like reading a water level in a class.
Okay.
If it's tilted too far one way or the other, you're not going to get an accurate reading.
Right.
We want to find that sweet spot where the pulsation is most visible,
Okay.
usually at the end of exhalation.
Gotcha.
Now, your notes also mention something called tracheal deviation.
Tracheal deviation. So the trachea can actually like move off center.
It can indeed.
Wow.
The trachea is normally right in the middle of your neck.
Okay.
But if something pushes or pulls it to one side.
Oh, like a collapsed lung?
Yeah, like a collapsed lung or a buildup of fluid or air in the chest, it can shift.
Wow. So if I see the trachea pulled really hard to one side, my first thought is tension pneumothorax.
Yeah, that's a real emergency.
Yes. But a subtle shift could be something less dramatic.
It could be something like atelectasis, a collapsed lung segment.
Right, so the amount of deviation kind of tells us the severity of the problem.
Exactly.
This is starting to feel like a detective novel.
Right.
So many clues.
So many clues to unravel.
Now, my notes jump to tripod positioning.
Okay.
So what's the benefit of leaning forward with your hands on your knees?
Think leverage.
Leverage.
It allows patients to engage those accessory muscles.
Accessory muscles.
Yeah, the ones in their neck, shoulders, and even abdomen.
Wow.
It's like giving their lungs an extra boost.
Fascinating how the body just finds ways to compensate when breathing gets tough.
It's amazing.
All right, let's move on to the skin.
Okay.
I wouldn't think the skin would tell me much about breathing, but apparently I'm wrong.
The skin is like a window into the body's inner workings.
Okay.
We've already talked about cyanosis, but there are other subtle clues to look for.
Like clubbing.
The clubbing.
That's where the fingertips become kind of rounded and bulbous.
Exactly.
So what causes that?
It's often associated with chronic hypoxemia, long-term low blood oxygen levels.
Okay.
Think of it as the body's attempt to increase blood flow to the fingertips.
Oh, to try to get more oxygen.
To try and get more oxygen.
It's amazing how the body adapts even at a cellular level.
It is really remarkable.
So my notes also mention pedal edema.
Okay.
So that's swelling in the ankles and feet.
Right.
How is that connected to breathing?
It's often a sign of right-sided heart failure,
Right.
which can be triggered by chronic lung diseases.
Okay.
Basically, the heart's struggling to pump blood efficiently and fluid backs up in the body, especially in the lower extremities, due to gravity.
Makes sense. So we're checking the skin for color changes, clubbing and swelling.
Right.
What about capillary refill?
Yeah, capillary refill, that's a quick and easy way to assess circulation.
So how do we assess that?
You basically press on the fingernail, blanch it, and see how long it takes for the color to return. If it's delayed, that could point to poor blood flow, maybe due to a weak heart or low blood volume.
So it's like a mini stress test for the circulatory system.
That's a good way to think about it.
Okay.
And finally, your notes mention peripheral skin temperature.
Okay.
So why would cold hands and feet be a concern in a respiratory assessment?
Yeah, why would that matter?
Well, when the body is stressed, like during severe respiratory distress, it tries to conserve heat and shunt blood to the vital organs.
The core.
Yeah, and that can leave the extremities feeling cool to the touch.
Makes sense. It's all about prioritizing where that blood flow goes.
Exactly.
Okay, we've covered a lot of ground with just visual inspection.
It's amazing how much you can tell just by looking.
It really is.
Now let's shift our focus to the shape of the chest.
Okay, the shape of the chest.
Yeah, is there really that much to learn just by looking at the chest?
I don't know, you tell me.
More than you might think.
Okay.
The chest shape can be a dead giveaway for certain conditions.
No.
For instance, patients with COPD often develop what's called a barrel chest
Okay.
due to chronic air trapping.
Right, so their lungs are constantly inflated.
Constantly inflated.
Like an overfilled balloon.
Yeah, like an overfilled balloon. And this changes the shape of their chest over time.
So we're looking for that telltale barrel shape.
Exactly.
What about other chest abnormalities?
Yeah, your notes mention some pretty cool medical terms.
Yeah, like pectus carinatum?
Pectus carinatum or pigeon chest.
Right.
Where the breastbone protrudes outward,
Hi.
kind of like a bird's keel.
Okay.
And then there's pectus excavatum.
Pectus excavatum.
Yeah, the opposite.
So the breastbone sinks inward.
Creating a dent or a hollow in the chest?
So one sticks out and one caves in.
Exactly.
And they both can affect breathing.
Yeah, they can restrict chest expansion and make it harder for the lungs to fully inflate.
Wow. Okay. My notes also mention kyphosis scoliosis and kyphoscoliosis.
Those are all related to the spine.
Okay.
So kyphosis is an excessive outward curvature of the spine, leading to that hunchback appearance.
Yeah.
Scoliosis is a sideways curvature, like an S shape.
Okay.
And kyphoscoliosis is a combination of both.
So we're essentially looking for any deviation from that normal symmetrical chest shape.
Exactly. Any curve or protrusion could signal a potential problem.
Okay, so much to look for just with the chest.
Right.
Now that we've assessed the chest shape, let's move on to the actual act of breathing.
Okay, so how a patient breathes can be incredibly revealing.
So what should we be looking for?
Well, first we assess the rate and rhythm.
Rate and rhythm.
Yeah. Is the breathing effortless and rhythmic?
Okay.
Or is it labored and irregular?
So we're looking for any deviation from that normal, smooth in and out pattern.
Exactly.
So what kind of abnormal breathing patterns should we be on the lookout for?
Well, there's apnea where breathing completely stops.
Okay, that's a bad sign.
That's a critical sign.
Yes.
And then there are various irregular patterns, like Wyatt's breathing.
Wyatt's breathing.
That one has unpredictable periods of apnea, and it's often linked to brain issues.
Okay, so irregular breathing could signal a problem with the brain's control centers.
Exactly.
Okay, my notes also mention Cheyne-Stokes breathing.
Ah, Cheyne-Stokes. That's like a crescendo and decrescendo of breathing.
A crescendo and decrescendo.
Yeah, it starts shallow, gets deeper, then shallower again, followed by a pause.
Wow, okay.
It's often seen in patients with heart failure or neurological conditions.
Okay, so Cheyne-Stokes, heart failure, or neurological.
That's right.
Okay, what are some other breathing patterns that we need to know?
Well, there's Kussmaul's respirations.
No?
They're deep and rapid, like the body is trying to blow off excess CO2.
I see.
You often see that in diabetic ketoacidosis.
Okay, that one seems pretty distinctive.
It is.
What about apneustic breathing and paradoxical respirations?
Those are a little more complex.
Um,
Apneustic breathing involves prolonged gasps for air,
Okay.
and that often indicates damage to the brainstem.
With the breath.
Yeah. And then paradoxical respiration, that's where the chest moves inward on inhalation and outward on exhalation.
Although that's the opposite of what it should be doing.
Exactly, and that suggests problems with the chest wall or the diaphragm.
So these unusual breathing patterns are like red flags alerting us to potential underlying problems.
They're like warning signs.
What about asthma? Does that have a specific breathing pattern we should be aware of?
Yeah, in asthma, the hallmark is prolonged expiration.
Prolonged expiration.
They have trouble getting air out because of those constricted airways.
Right.
And so you'll hear wheezing, especially on exhalation.
It's like the air is struggling to escape.
Yeah, it's trapped.
Okay. And what about COPD? Does that present differently?
COPD patients also have prolonged expiration, but their breathing is often shallow and rapid,
Okay.
and they might purse their lips to help keep those airways open.
So we're not just counting breaths per minute.
No.
We're paying attention to the entire cycle of inhalation and exhalation.
Exactly. We're looking for signs of struggle or irregularity.
Okay. And we're also watching for the use of accessory muscles and retractions.
Right. Those are signs of increased work of breathing.
Can you explain why those are so important?
Yeah. So when someone is really struggling to breathe, their body will recruit those extra muscles to help expand the chest.
Oh, so like the neck muscles, the shoulders.
You might see their neck muscles straining their shoulders, heaving even their abdomen working hard.
So it's like their body is calling in the reinforcements.
Exactly.
And retractions.
Retractions are where the skin sinks in between the ribs or in the neck when they breathe in.
Okay.
It's a sign that they're really having to work hard to pull air into their lungs.
Okay. So we're watching for those signs of labored breathing.
Right?
And my notes also mentioned abdominal paradox and respiratory alternance.
Ah, yes. Those are signs of diaphragmatic fatigue.
So the diaphragm's getting tired.
Exactly.
Yeah.
So in abdominal paradox, the abdomen moves inward during inspiration.
Oh, so the opposite of what it should be doing.
Exactly. And then respiratory alternans is this alternating pattern of deep breaths followed by shallow breaths.
So it's like the diaphragm is trying to get a break.
Yeah, that's a good way to put it.
So much information just from observing the breathing pattern.
It's amazing what you can learn just by watching.
Okay, now my notes transition to palpation.
Okay.
So time to get hands-on.
Time to get hands-on, but with a purpose.
But with a purpose, right?
Yeah.
What are we trying to feel for when we palpate the chest?
We're trying to confirm what we're seeing and hearing.
Okay.
So, for instance, if we suspect a patient has pneumonia,
Okay.
we can actually feel that increased density through palpation.
How do we do that?
Well, one technique is to assess tactile fremitus.
Tactile fremitus. Okay.
So we have the patient say 99,
99.
while we feel for the vibrations transmitted through the chest wall.
So what are we feeling for?
We're feeling for any differences in the vibrations.
Okay.
So if there's increased fremitus over a specific area, that could point to consolidation like you see in pneumonia.
It's like we're feeling the sound waves traveling through the lungs. It is. That's so cool.
And what about decreased fremitus?
Decrease, what would that tell us?
That could indicate air or fluid in the pleural space,
Okay, like in
like in a pneumothorax or a pleural effusion.
Yeah.
It could also point to an obstruction blocking the sound waves.
So it's all about comparing the vibrations felt in different areas of the chest.
Exactly. We're looking for symmetry or asymmetry.
Right, symmetry is key.
So increased fremitus might mean pneumonia,
Okay.
while decreased fremitus could be something like a pneumothorax.
Got it. So we're checking for the amount and symmetry of chest expansion.
That's right.
And while we're at it, we're also feeling for any tenderness or unusual masses.
Absolutely. We want to make sure nothing feels out of place.
Okay, and speaking of unusual findings, have you ever felt subcutaneous emphysema?
Subcutaneous emphysema.
That's where air leaks from the lungs into the tissues.
It's a bizarre sensation.
I've heard it described as like bubble wrap.
Yes, it's like crackling Rice Krispies under the skin.
Rice Krispies, that's a good one.
It can be a sign of a pneumothorax.
Okay, so we've inspected the chest, palpated for abnormalities, and now it's time to channel our inner percussionist.
Right, but instead of a drum, we're using our fingers to tap on the chest.
So we're basically tapping into the secrets of the lungs.
Exactly. And just like a drummer can create different sounds depending on where and how they strike the drum,
Right.
we can elicit different sounds based on the density of the underlying tissue.
So what kind of sounds are we listening for?
Well, the three main sounds are resonant, dull, and hyperresonant.
Okay, break those down for me.
So resonant is that nice hollow sound you hear over normal lung tissue.
Okay. Resonant normal.
It's like tapping on an empty box.
$70, okay.
Dullness is a quieter, thud-like sound.
Dullness.
And that's heard over areas of increased density.
Okay, so like
tapping on a water-filled container.
Okay.
It could indicate fluid buildup, like in pneumonia or a pleural effusion.
So dullness equals density.
Exactly.
Okay, what about hyperresonant?
Hyperresonant is a very loud, booming sound.
Okay.
And that's heard over areas of increased air, like in a pneumothorax or severe emphysema.
So if I hear a drum-like sound, I should be thinking pneumothorax.
It's definitely on the top of the list.
Okay.
But remember, we need to consider all the findings together to paint a complete picture.
Right, it's all about connecting the dots.
Exactly.
Okay, we've covered a lot of ground already. Inspection, palpation, percussion. But something tells me auscultation, listening to the breath sounds, is where it all comes together.
You're absolutely right.
Okay.
Auscultation is arguably the most important part of the respiratory assessment. It's where we get to hear those subtle whispers and crackles that tell us so much about what's happening inside the lungs.
I'm ready to tune in and listen. So what kind of breath sounds should we be listening for?
Well, there are three main types of normal breath sounds: vesicular, bronchovesicular, and bronchial.
Okay, break it down for me.
So vesicular sounds are soft and rustling, like wind through the trees.
Okay.
And they're heard over most of the lung fields.
Vesicular wind through the trees. I like that.
Now, what about bronchovesicular and bronchial sounds?
Yeah.
Bronchovesicular sounds are a bit louder and harsher,
All right.
heard over the larger airways.
All right.
And bronchial sounds are loud and tubular,
Okay.
and they're heard over the trachea.
So we're listening for those different breath sounds and making sure they're heard in the right places?
Exactly.
But what about those abnormal sounds that my notes keep mentioning? The crackles, wheezes, and raunchy?
Those are called adventitious breath sounds.
Adventitious breath sounds. Okay.
And they indicate that something's not quite right in the lungs.
Okay.
So, for example, crackles sound like Rice Krispies in milk
Okay.
and usually point to fluid in the airways.
Okay, so crackles fluid.
Exactly.
What about wheezes?
Wheezes are a sign of narrowed airways, like in asthma or COPD.
Okay.
Imagine trying to breathe through a straw.
Yeah.
That's essentially what's happening in their lungs.
Okay, so crackles fluid, wheezes narrowed airways,
Right?
and
Raunchy are lower pitched and suggest mucus or secretions in the larger airways.
so like gunk obstructing the airflow.
Exactly. And they often clear with coughing, so that's a good sign to listen for.
Good to know.
Now, what about stridor?
Stridor. Okay.
That's a high-pitched, harsh sound heard on inspiration,
Okay.
and it's a sign of upper airway obstruction.
So like,
Think croup epiglottitis or even a foreign object lodged in the trachea.
oh, that's scary.
It's considered a medical emergency
Yeah?
and requires immediate attention.
Wow. So just by listening carefully, we can gather so much information.
It's amazing what those breath sounds can reveal.
It really is. The more you practice auscultation, the better you'll become at recognizing those subtle nuances.
It's like learning a new language.
The language of the lungs.
The language of the lungs.
I love that analogy.
Right.
This has been incredibly insightful. We've covered a lot of ground in just this first part of our deep dive. We've talked about inspection, palpation, percussion, and now auscultation.
We've laid the foundation.
I'm already feeling more confident in my ability to assess respiratory distress.
That's great to hear.
But we've only just scratched the surface, right?
We've only just begun.
There's so much more to learn.
There is.
Yeah.
I can't wait.
Welcome back to our deep dive, ready to put those honed auscultation skills to the test.
Absolutely. I'm eager to apply everything we've learned so far to some real-life scenarios.
Let's do it.
My notes delve into some specific respiratory conditions,
Okay.
and I'm particularly interested in the ones we're likely to encounter pretty frequently in practice.
Great point. Let's start with asthma.
Asthma.
It's incredibly common and can present with a wide range of severity.
Okay, so when a patient with asthma walks through the door, what's going to be my first clue?
Well, they'll likely be complaining of shortness of breath, wheezing, and a tight feeling in their chest.
So it's like trying to breathe through a straw.
Exactly. They might also have a cough, especially at night or early in the morning.
Okay, so I'm listening to their story. I'm already thinking asthma.
What am I looking for during my exam to kind of confirm my suspicions?
Well, you'll probably see them breathing rapidly. We call that tachypnea.
Tachypnea, okay.
And you might see them using their accessory muscles, those extra muscles in their neck and shoulders to help them breathe.
Right, like their body is calling in the reserves.
Exactly.
And when I put my stethoscope to their chest, What am I going to hear?
Wheezing is the classic hallmark of asthma.
Wheezing.
It's that high-pitched whistling sound caused by air squeezing through those narrowed airways.
Oh, okay.
You'll likely hear it more on exhalation, but it can occur on inspiration too.
So wheezing equals asthma?
Not necessarily.
Okay.
Wheezing can occur in other conditions too, like COPD or even heart failure.
Right. It's all about the whole clinical picture.
That's why it's so important to consider the whole clinical picture.
Their symptoms, their history, and all the findings from the exam.
Exactly.
Okay, speaking of COPD, how does that present differently from asthma? They both involve airway obstruction, right?
They do, but COPD is a bit more insidious. It develops gradually, often over years of smoking or exposure to other irritants.
Okay.
And patients with COPD usually have a chronic cough with sputum production.
Okay.
And they may experience shortness of breath, especially with exertion.
So if I see someone who's barrel-chested, has a chronic cough, and is breathing through pursed lips, I'm thinking COPD.
Those are all classic signs of COPD.
Okay.
Especially that barrel chest.
Barrel chest.
It's caused by air trapping in the lungs.
Right.
Which over time can actually change the shape of the chest.
And that pursed lip breathing, is that helping them?
It's a clever way for them to create back pressure and keep their airways open longer.
So it's like they figured out their own treatment strategy.
In a way, yes.
Okay, so what am I going to hear when I auscultate their lungs?
You might hear diminished breath sounds, meaning they're quieter than normal.
Okay, quieter breath sounds.
You might also hear wheezing, and crackles are possible, especially if they have an infection on top of their COPD.
So we're listening for quieter breath sounds, wheezing, and maybe some crackles? Now, my notes also mention pneumonia.
Pneumonia.
Seems like everyone gets pneumonia at some point.
It's very common.
What am I looking for in a patient with pneumonia?
Well, the classic symptoms are fever, cough, chest pain, and shortness of breath.
Okay, so they're feeling pretty miserable.
They usually don't feel great.
Yeah.
Yeah.
What about the physical exam? What are the key findings?
Well, they'll likely have a fever.
Okay.
And you might see increased respiratory rate and use of accessory muscles.
Right.
If you palpate their chest, you might feel increased fremitus over the affected area.
Okay.
And percussion could reveal dullness over that consolidated lung tissue.
Okay, so I'm thinking pneumonia. I feel increased fremitus, and I hear dullness on percussion. What about auscultation? What's the clincher sound that's going to seal the deal?
Crackles are going to be your biggest clue here.
Crackles.
It's that sound of air bubbling through fluid in the alveoli.
Okay.
The tiny air sacs in the lungs.
So crackles plus fever, cough, and those other findings pretty much scream pneumonia.
They make it very likely.
Now let's switch gears to a slightly trickier condition. Pulmonary embolism, or PE.
Okay, PE.
This one can be a real chameleon, right?
It can be tough.
It often presents with nonspecific symptoms.
It does.
So for our listeners out there, PE, that's where a blood clot travels from somewhere else in the body, usually the legs,
Right.
and lodges in an artery in the lungs.
Exactly.
So what should raise my suspicion for a PE?
The most common symptom is sudden onset shortness of breath.
Okay, sudden shortness of breath.
They might also complain of chest pain, which can be pleuritic, meaning it worsens with deep breathing.
Okay.
And they might have a cough sometimes with blood-tinged sputum.
So sudden shortness of breath, chest pain, and cough. That sounds pretty generic.
It can be tough to distinguish from other things.
Right. So what am I looking for on exam to help me differentiate a PE from, say, a panic attack or something less serious?
Unfortunately, the physical exam can be surprisingly unhelpful in PE.
Really?
You might see tachypnea, rapid breathing,
Okay.
and tachycardia, a fast heart rate. And they might have a low-grade fever,
Right.
but there are often no specific lung findings on auscultation.
So how on earth do we diagnose a PE if the exam is often normal? It sounds like a real diagnostic dilemma.
It can be. That's why it's crucial to consider the patient's risk factors.
Okay, risk factors like...
Have they had recent surgery?
Okay, recent surgery?
Are they immobile?
Immobile. Okay.
Do they have a history of blood clots?
So those are all red flags.
Those are all red flags that should raise your suspicion.
So it's a high-stakes game of detective work.
It can be.
We need to piece together their symptoms, their risk factors, and our clinical judgment.
Right.
To decide if further testing is warranted.
Exactly. PE is a serious condition that requires prompt diagnosis and treatment.
Okay, I'm making a mental note to always consider PE, especially in patients with sudden shortness of breath and those key risk factors.
It's good to have a high index of suspicion.
Now, I know we could spend hours discussing every possible respiratory condition, but this overview of asthma, COPD, pneumonia, and PE has given me a great starting point.
I agree. We've hit some of the heavy hitters.
Yeah.
And we've highlighted the key features that can help you distinguish between them.
Right. But remember, real-life medicine is always more complex than a textbook case.
Of course.
But having this framework in my mind is incredibly helpful.
It's a good foundation.
I feel much more equipped to approach a patient with respiratory distress and start narrowing down those possibilities.
That's the goal.
So practice experience and always keep learning.
Absolutely.
That's the key.
And speaking of learning, I think it's time to shift gears
Oh, we think.
and explore another crucial aspect of respiratory assessment.
Okay, what's that?
Your notes mentioned differential diagnosis.
Differential diagnosis, that sounds intimidating.
It can be a bit overwhelming at first.
Yeah, so essentially it's coming up with a list of possible explanations for the patient's symptoms, right?
Exactly. It's
Yeah.
like putting together a puzzle.
Okay.
But instead of pieces, we're using clinical data, the patient's history, their exam findings, and any diagnostic test results.
So if someone comes in with shortness of breath, our differential might include everything from asthma to a heart attack to anxiety.
That's right. The goal is to consider all the possibilities,
Right.
then systematically rule them in or out based on the evidence.
So this is where our detective skills really come into play.
Exactly.
We need to be methodical, observant, and always thinking one step ahead.
That's the key. And sometimes it's a process of elimination.
Right.
We might not have a definitive answer right away,
Yeah.
but by carefully analyzing the clues,
Right.
we can narrow down the possibilities and arrive at the most likely diagnosis.
This whole process of differential diagnosis reminds me of something I read in your notes. The importance of considering the patient's overall clinical picture.
That's crucial.
Okay.
It's not just about memorizing a list of signs and symptoms.
Right.
It's about understanding how they all fit together to tell the patient's story.
So we're not just treating a set of lungs.
Right.
We're treating a whole person.
Exactly. Their age, their medical history, their lifestyle, all of these factors can influence their presentation
Okay.
and help guide our diagnostic thinking.
Wow, this is making me realize that respiratory assessment is so much more than just listening to breath sounds.
It is.
It's about connecting with the patient, understanding their story, and using all the tools at our disposal to piece together the puzzle of their illness.
Well said. It's a blend of science, art, and good old-fashioned detective work.
I like that. Okay, I'm feeling ready to tackle some differential diagnosis challenges.
All right.
But before we jump into that, I think it's time for a quick recap.
Okay.
So we've covered a lot of ground in this second part of our deep dive.
We have.
We've talked about the key features of asthma, COPD, pneumonia, and PE,
Right.
and we've emphasized the importance of differential diagnosis
Yes.
and considering the patient's overall clinical picture.
Exactly.
I'm feeling much more confident and prepared to approach a patient with respiratory distress.
That's fantastic to hear.
And remember, the learning never stops. With each patient encounter, you'll gain new insights and refine your skills.
You'll become a better clinician.
So keep practicing, keep asking questions, and most importantly, never lose that curiosity.
Curiosity is key.
There's always more to discover in this fascinating world of respiratory assessment.
Absolutely. And on that note, let's take a short break and come back for the final part of our deep dive,
Okay.
where we'll tackle some real-life case scenarios and test your diagnostic skills.
All right, listener, welcome back for the final part of our respiratory assessment deep dive. Are you ready to put all that knowledge to the test?
I hope you've been paying attention because we're about to tackle some real-life scenarios.
Okay, game on.
That will really make you think.
Let's start with something straightforward.
Okay.
Imagine a patient walked in, clearly struggling to breathe.
Okay.
They're using those accessory muscles we talked about, and their breathing is shallow and rapid.
Right.
They're coughing up thick yellow phlegm and complaining of chest pain.
Mm-hmm.
That's worse when they take a deep breath.
Yeah.
Where do you even begin with a case like this?
Well, first I'd take a deep breath myself and try to stay calm.
Okay.
It's easy to get overwhelmed when a patient's in distress. But remember, we have a systematic approach for a reason.
Right.
We've got our trusty inspection, palpation percussion, and auscultation skills to guide us.
Okay, deep breaths. Got it.
So you're looking at this patient and they're clearly working hard to breathe.
Right.
What are you specifically looking for during your visual inspection?
Okay, so I'm looking at this patient, and like you said, they're working hard to breathe.
Yeah.
What am I looking for specifically?
You already mentioned the accessory muscle use,
Right.
which is a big clue.
Right.
Check their breathing rate. Is it fast? Are they gasping for air?
Go.
See if you can spot any cyanosis.
Okay.
And don't forget to look at their chest. Are they holding it stiffly to minimize pain?
Okay. All important clues. So I'm picturing a patient hunched over, struggling to catch their breath.
Right.
Let's say their breathing rate is elevated and they have a slight bluish tinge to their lips.
Oh.
What's next?
Time to get hands-on with palpation.
Palpation.
Okay. Feel for their chest expansion. Is it symmetrical?
Okay.
Is one side lagging behind?
Gotcha.
Remember that tactile fremitus technique we talked about?
Yes. 99.
Have them say 99 and see if you feel any increased vibrations.
Okay.
That might point to consolidation.
Okay, let's say I feel increased fremitus over the right lower lobe. What does that tell me?
It suggests something is making that part of the lung denser than usual.
Okay.
Could be fluid, like a pneumonia, or maybe a mass.
So increased fremitus is making me think pneumonia.
Right.
Time for percussion.
All right, let's tap.
What kind of sounds am I listening for?
If you're suspecting pneumonia, you'd expect to hear dullness over that right lower lobe.
Dullness.
It's that thud-like sound that indicates something denser than air is filling the alveoli.
All right, so far we've got labored breathing cyanosis, increased fremitus, and dullness to percussion. It's all pointing towards pneumonia.
It's looking that way.
But we're not done yet, right? Nope. You gotta listen.
What's the final piece of the puzzle?
Auscultation, of course.
Of course.
It's time to break out your stethoscope and listen to what those lungs are trying to tell you.
Oh, okay. Stethoscope on. I'm ready to listen.
All right.
What am I hoping to hear, or maybe not hear, that would confirm a diagnosis of pneumonia?
If it's pneumonia, you're likely to hear crackles over that right lower lobe.
Crackles.
Remember, it's that sound of air bubbling through fluid in the airways.
So if I hear Rice Krispies in their lungs, I can be pretty confident it's pneumonia.
Along with all those other findings you mentioned, yeah, crackles pretty much seal the deal.
This is amazing. I'm starting to feel like a real respiratory detective.
You're getting it.
But before we move on to another case, can we back up for a second and talk about differential diagnosis again?
Sure.
It seems so crucial in respiratory assessment, but also a bit overwhelming.
It can be. Remember, good differential diagnosis is like a well-crafted detective story.
You gather clues, you consider all the suspects, and you systematically narrow down the possibilities until you reach the most likely culprit.
So for this patient with suspected pneumonia, what else could have been on our list of suspects?
Well, we always have to consider the possibility of a pulmonary embolism,
PE.
especially in patients with chest pain and difficulty breathing.
Right.
A PE can be tricky because its symptoms can mimic other conditions and the physical exam findings can be subtle.
Right. PE is always on the back of my mind, especially if the patient has any risk factors like recent surgery or immobilization.
Exactly. Those are big ones.
What else could mimic pneumonia?
Well, heart failure can also present with shortness of breath, cough, and crackles on exam.
Okay.
The key is to listen carefully to the crackles.
Oh, okay.
In pneumonia, they're typically finer and heard primarily on inspiration.
Okay.
In heart failure, the crackles tend to be coarser and can be heard on both inspiration and expiration.
So the type of crackles can give us a clue.
It can.
This is where experience and a trained ear really come in handy. Yeah. Don't forget about those less common possibilities like lung cancer or even an aspirated foreign body.
Right. We have to keep an open mind and consider all the options.
Even if they're less likely.
Even if they're zebras.
This whole differential diagnosis process feels like a constant balancing act.
It is.
Considering the common and the uncommon, the obvious and the subtle.
And sometimes we don't have all the answers right away.
Right.
We might need to order additional tests like a chest x-ray or a CT scan to help clarify the diagnosis.
Okay, I'm starting to see how all of this comes together.
Good.
We use our clinical skills to gather clues,
Yep.
develop a differential diagnosis,
Right.
and then use further testing to confirm or rule out our suspicions.
Exactly.
It's like building a case piece by piece.
That's a great way to think about it.
And remember, even when we have a diagnosis, our work isn't done.
Right.
We still need to figure out the underlying cause and develop an appropriate treatment plan.
Exactly. The investigation continues.
This has been incredibly eye-opening. I feel so much more equipped to tackle these respiratory assessment challenges now.
That's what we were hoping for.
And I think the most important takeaway for me has been the reminder to always be curious.
Yes.
To never stop asking questions and to always keep learning.
Couldn't have said it better myself.
Well, listener, I think we've reached the end of our respiratory assessment deep dive.
You made it.
We explored the intricacies of inspection, palpation, percussion, and auscultation.
We did.
We tackled some real-life case scenarios.
We did.
And delved into those complexities of differential diagnoses. And most importantly, we emphasized the importance of lifelong learning and approaching each patient with curiosity and compassion.
That's what it's all about.
Remember, every breath tells a story.
It does.
Listen carefully, and you'll unlock those secrets of the lungs.
Until next time.
Happy breathing.